Get back on.
Oh, we're back. We're back.
Oh,
Okay, everybody, we're back.
all right.
Hi.
Great, thank you.
That's a new version.
I know.
Sorry for the interruption, and the new camera angle. For some reason, we all look really super pale.
Go ahead. Okay, thank you. All right, so I think I was talking about the individual market, and how we've seen a significant decrease in enrollment. With that happening, we saw, the insurers, the two insurers who provide coverage in that market coming in with premium increases to account for that, that loss of enrollment. And then we're also expecting more coming down from the federal government on a kind of a different approach to silver loading, which will add costs and increase premiums. And then other policies that are focused on fraud, waste, and abuse, which don't necessarily prevent people from enrolling or change the requirements, but can make it more burdensome so that some people then, whether it's because they don't have someone helping them or they can't figure it out, maybe miss their chance at the open enrollment. So we're seeing a lot of things coming at that market. And I think because the Green Mountain Care Board is the one in charge and required to approve premium rates for this market, we felt it was appropriate to try to target, at least in the interim, some cost savings through reference-based pricing to this market. Not only does our proposal in S-190 address individual market, it would also provide reference-based pricing for the small group market. And I think generally the small group market, the employers who are purchasing plans from there, if they have the ability to go self-insured or purchase an alternate coverage, a lot of the time those options are cheaper. But there are a lot of small employers in this purchasing their plans through the small employer, small group market because they don't have other options. Generally, the plans for the QHP market for small employers tend to be more expensive. That's why the employers will look for other alternatives in the self-insured market so they can access lower prices. They might have more flexibility with benefit design. They're not subject to the same regulatory requirements as the small group market. So often, if you can go and purchase a lower price option from either doing it through an AHP or an ERISA self-insured plan. So the reason I bring that up is because all small employers and just employers generally are not starting from the same place. Usually small employers who are purchasing in the small group market are doing so because they can't or don't have other options, usually paying a higher price. So when we're talking about spreading the savings to everyone, yes, we agree with that, but we have a market right now which is literally functioning as a market of last resort. And without immediate relief to that market, we are concerned that there will be further either individuals deciding to go uninsured or small employers who can't offer their employees coverage for the following year. So really believe that market is in crisis right now, and we want to and feel we should do something for those consumers who are in that market. I think I brought up the fact that not all small employers are able to go self-insured. Many times if you have employees who maybe have high claims or are older, they tend to have more health issues. You don't necessarily always have the option to go self-insured. So again, it's not that all small employers have this alternative option. There's definitely a disparity there between the small employers who are in the small group market and those who have access to alternate coverage plans. So again, this market is acting and functioning as a market of last resort. And I think we've all seen the recent news articles about the just national drop of enrollment in the QHP plans. And so we really would like to stabilize this and implement this cap. I just want to reiterate, we do acknowledge and support a system-wide approach, which is why we're doing reference-based pricing. And I think I'll end there and take any questions.
So in the beginning, you said something about, if I get the language wrong, I'm sorry, because it was
Okay.
15 minutes ago, but something around all reference-based pricing for all commercial plans. And Medicare, we don't regulate, but we use as a benchmark for the reference-based pricing. And then Medicaid, how does Medicaid fit in?
Medicaid has their own pricing. And
Is it
so
connected
that
to the Medicare price in any way?
I can't answer that. I'm not sure. Yeah.
But is it, do you know if it's closer to the Medicare price than the commercial prices?
I don't,
We'll look into
Yes.
it. Okay.
may not Verity.
So I just wanted to clarify that.
Okay.
And then this is like probably the far-fetched question. But you talked about the unique challenges facing the qualified health plans because of federal changes. This probably would need a waiver, but like, are you allowed to offer Medicaid as a qualified health plan?
I believe to get into Medicaid, there's income requirements. Is that what your question?
No,
is?
like
Sorry.
could people pay the full price for Medicaid and purchase it instead of MVP or Blue Cross Blue Shield on the market? Like is it, or is that like too far-fetched right now? I think it would probably need a waiver, but I don't know.
Yeah, I would defer to HS on that. I don't know the answer.
Okay, all right, that's fine. We'll save the question.
Need a waiver.
Yeah,
It's not that important. It gets the answer today. It just came to mind if we're like trying to control
Yeah.
the prices. Medicaid is already controlled. It might be a way, I guess, anyway, whatever. I was just thinking about how we can extend the benefits.
so I think another way to answer your question is right now, individuals who are purchasing QHP plans, they either don't have an employer-sponsored coverage or their employer-sponsored coverage has been deemed too expensive. There's an income threshold which allows you to get into the individual market. So that is their only option. The individual market for those in it, there's no other market that's available right now in Vermont where you can go and buy a comprehensive major medical plan.
I'm in
Yeah.
it and like I have two choices and the cheapest one is like $800 and something a month with
Exactly.
like a 12 or 13,000 or 14,000.
Exactly.
It's ridiculous. So I appreciate your effort to give us relief.
You were talking about like who has the option of self-funded.
Mhm.
So even if you're a smaller employer, there are options for you. I think,
Yes.
I can't remember the word for it, the broker that was here last week. Level funded, thank
Yeah.
you.
Yep.
Level funded. But also you just said that, there are certain employers based upon like the employees that they have.
Yep.
So in essence, aren't we leaving the only companies that have an option in the small group with a higher risk pool,
Correct.
which then of course increases the cost across the entire risk pool? I mean, aren't you removing the healthy populations out of?
Yes, so if you, right now, if you're a small employer and you're looking at your options, you're maybe working with a broker, you are going to try to find the most cost-effective, best plan for your employees, right? That's a smart business decision. If you can go and purchase a level funded plan, right, whether you're working, doing the Blue Edge program, or if you are big enough of a small employer, I know the insurers tend to now, because of the ability to reinsure a lot of your risks, which is called stop loss insurance, they're going smaller and smaller. So some small employers can actually go and be level funded, and that counts as being self-insured under ERISA. But you can go and buy a plan that's not in the QHP market. So yes, so what happens is essentially if you aren't allowed to do that, or if you don't have that option and you want to offer your employees coverage, you have to purchase that through the QHP market. And therefore, if you're staying there, you tend to have, you don't have the ability, which means an insurance company has kind of looked at your employee pool and said, that's not a good risk for us.
I'm sorry, I had a question and it just left my mind. Completely gone. Any other questions for Emily? Oh, yeah, go ahead, Wendy.
I have a question. So this is starting off with the QHBs.
Mhm, correct.
Eventually, we're gonna do more.
Next year. Yep.
Is that in this bill? Like, how do we know next
Yeah,
year?
so
we're gonna do
there's
this?
a separate bill, which was Act 68. Is that accurate, Elena? Act 68, which was passed last year, which required the Green Mountain Care Board to begin implementing reference-based pricing in FY 27. So we are.
That would be the bulk of the rest
Correct,
all at
exactly.
once?
Yep, and that will be a phased-in approach. So something else I heard last week was this concern about the financial stability and sustainability of our healthcare system. If we did all commercial insurance right now at 250 or 300, our hospital system could not absorb that.
Mhm.
That would be too much of a financial hit in 1 year.
Can you say that again?
Yep,
Slower.
so if we changed our proposal here, instead of just being the QHP market, if we then said, actually, all of the commercial market will get 250%, with the prices they pay will be capped at 250% of Medicare. The cost or the financial impact to hospitals would be too much for them to absorb in 1 year.
I get it now. I get it.
So what we're doing, just to provide context too, what we're doing with our contractor for reference-based pricing is they're actually going to be able to do a financial impact of a reference-based pricing plan. So let's say year one, we want to get all payers or all prices down to 300%, or we say that's our goal, right? They would be able to look at the hospital system and say, okay, if you did that, this would be the financial impact of that. So part of the work we're doing is to how fast can we go, right? To make sure that our hospitals and our healthcare system have time to adapt to those changes. That is going to be implemented over a multi-year plan. So it won't just be that next year, everyone is at the national median for hospital costs. That will be a year-over-year approach where we then get to hopefully closer to the national median for healthcare costs at hospitals.
And so this is
Does that make sense?
as the plan for incremental implementation, I'll put it that way, of reference-based pricing. Through the whole, as that's being sort of planned, you feel like this is a safe first step we can take.
Correct.
Yeah, it's like the safest thing we can
Not
do.
only a safe first step, but a necessary from a
Okay.
policy perspective. We don't regulate the ERISA market, the self-insured market. I think Commissioner Sampson had talked about, there's an additional 75% of the market that is the self-insured. We largely don't regulate that. So we can't control the premiums there. We can't say that, oh, you're getting these savings, so make sure that money goes back to Vermonters. We don't have control over that. We do have direct control over QHP premiums. So we approve that. We can make sure that that money gets back into Vermonters' pockets through reduced premiums. And then also when you reduce healthcare costs, when you reduce costs of hospitals, then when you have your high deductible health plan and you go to the hospital and you're receiving care, it's not only reducing your premium, it's then lowering your actual cost share so that you're maybe able to access more care because you're actually paying less. Like if you have a co-insurance or you have a high deductible, you're actually going to be getting more benefits for less money. So there's kind of this double impact where it's not only reduced premium, it's actually reduced costs when you actually have that patient interaction.
Or you're able to actually afford a
Right,
higher
exactly. Yep,
level plan, so you don't fear going
Exactly.
and
yep,
getting services because you have a $40,000 family deductible.
Yep. exactly.
Can I just follow up just?
Oh, yeah.
Of course. So I just want to understand. So when you do roll out the others, it may not be at 250%. You're basing this off this pilot that you're doing.
Correct.
Okay.
Yep.
That's.
Yeah, it's not next year,
Mhm.
when we start implementing this. Like I said, there's no way we could, if we wanted our hospital system to have time to react,
Sure.
it wouldn't be a smart regulatory approach to immediately put at where we want to get.
Mhm.
That will be something that we hopefully will be able to signal to everyone and say, okay, this is where we're going to get, this is how long it's going to take us to get there. This is the plan,
Okay,
so that we can all take time to adjust and hospitals have time to, if they need to, transform and change. So it's definitely going to be a system-wide approach, but we recognize that change doesn't happen overnight.
Sure.
And so that's the point of the multi-year
Okay.
phase, and yeah. Thank you.
Thank you. I feel like I should know the answer to this already. So when you talk about the hospitals transforming, changing to that cap, correct? That's what you were referring to. Do they have a flexibility? I don't even know if it's wrong to change prices in other areas to make up for that?
Yeah.
Interesting.
So I think I'll just say so many prices right now are below, let's just say that we end up getting at 250% of Medicare. Like that's where we want to end up. A lot of prices that hospitals charge are below 250% of Medicare. They're not all above that area. And so when we're starting to think about reference-based pricing, and especially what care we want at hospitals, there's probably going to be a part of that analysis will be, okay, what kind of services do we want to prioritize at hospitals, and what should they be being paid for those services? And then what services do we maybe want to move out of hospitals? And so what are the costs for those? So I think there's definitely going to be flexibility, but I think the idea is to get a really thoughtful approach to how do we incentivize care to be offered where we want it to be offered, while also realizing that some care might be better outside of hospitals and some care might be better inside of hospitals. And I would be remiss to not mention that we currently don't only have authority to do reference-based pricing in hospitals. We actually have provider rate setting authority right now, full stop. So for even providers that aren't hospitals, we have the ability to rate set. And I'm going to look to my director of policy, Elena, to make sure that's accurate. Yes.
Brian?
So, I have two questions. Two additional questions. Thank you. One is there any other component? So one of the ideas that was brought to us was the idea of maybe adding in a component of hospital care for everyone. So it's like, or it's like a radiology, for example, or something. Is there any component of hospital care we might consider testing out reference-based pricing for the entire population? Is there anywhere, or have you deemed it completely too dangerous to push it in that regard?
Are you talking about the proposal to identify, for instance, like radiology or lab?
Yes. I think it was Blue Cross Blue Shield that I don't want to put words in people's mouths, but I'm pretty sure that's.
Yeah, so I think right now, and it's my understanding that that's a plan that's already being implemented, so they don't need legislation
Okay.
to lower those prices. They could decide right now that that's the negotiating strategy they want to use.
But then what about the other
their
payers,
prices.
like MVP or Medicaid or?
So, well, MVP is the only other insurer in the QHP market.
Okay.
I can't speak to, I think they have some large group business, but we haven't done an analysis to say all self-insured plans, like what would it look like if you brought down those prices, and targeted those.
Is that something that might be a second step if it's not possible this year?
It's part of the next phase.
It is,
right?
okay.
So we're going to be looking at different ways of phasing this in. So that is absolutely, having a comprehensive approach is really important so that, we know exactly what's changing. And we don't, provide too much risk to the system or don't kind of reduce enough savings. So that is exactly the exercise.
And then the second question is,
For the
Elena
record.
Barabee.
Oh, yeah.
Fremont Care
Oh, yeah, thank you. The second question is that the NEA, the Vermont NEA and the Vermont VSEA combined have like about 20,000 members. So those are 20,000 additional Vermonters, and I'm just curious what it might look like to do that population sooner rather than later,
Yeah.
especially since the idea came from them.
Yeah. So I believe the board did a study, it was either last year or the year before, that analyzed what it would look like if you reference-based priced the VSCA and the high
Yes.
to 200%, and there were significant savings if that was done as well.
But do you have any idea where that fits in the timeline? Like, would that be a next
Oh,
step?
I'm
or
sorry.
Could
Well,
that be
it-
done soon? Like, could we do that now, or is that too much to do at once for the hospitals?
So I think it would depend on what number you would peg it at, if it was at 250. I don't know. I don't have an answer right now at my
Okay.
fingertips for. what
Thank you.
that would look like.
Yeah.
Yeah.
And I think what I'm getting at is I'm thinking every possible way we might be able to push a little further with the reference-based pricing right now, considering the crisis we're in.
Yeah. Yeah,
Thank you.
Let's move to Commissioner Sampson.
Thank you.
And we'll have Jen sort of show us some language that been working on, and we can discuss that, and then we'll go to the healthcare advocate. Just to let everybody know, I know other people may have obligations, but we are going till 4:30 today. We'll be done at 4:30, and we will be taking a break.
Well, how soon is the break?
As soon as Commissioner Sampson finishes.
2 hours.
Okay, I'm gonna listen remotely for a second.
Kai Sampson, Commissioner of DFR. You asked me to talk about stop loss insurance.
Mhm.
Would also like to spend a couple minutes responding to, the trajectory of S-190 and bringing back some of my prior testimony. To Rep. Sina's question, no, the hospital system, which I'm not responsible for, but I've seen enough to understand that they cannot afford 250% reference-based pricing across the board. And I wanted to make sure that there's no confusion that from the administration's perspective, the strong desire to move this to apply to all commercial insurance isn't at 250. That's entirely scalable. Maybe the right number is 550 as a cap and, across the entire, whatever the number is. Or perhaps, as you've heard testimony from Blue Cross, perhaps the first step is across commercial insurance. Let's focus on lab and radiology. So it's about what's the right number that can be afforded by the hospital system in 2027. And the real question is, okay, if the number is 100 million, we can do 250% cap on the QHP, as is what's in the bill now. But there is a number, and Blue Cross can provide that number, and with help from MVP, and they have those numbers, and we've extrapolated those numbers to the entire market. But there is a number that takes the same amount, more or less, from the hospital system in revenue reductions and applies reference-based pricing across all those markets.
Can I stop you for just 1 second?
Yes.
You alluded to it in your first. So who can calculate out, or who is best to determine how much the hospitals can, I'm going to use the word withstand here, so it's probably not absorb. Green Mountain Care Board?
Absolutely their authority. Yep. And that's testimony happens and what happens in budget guidance and then in their budget orders and hearings. But clearly they have a sense of that. They've given guidance that shows, I think, about 40 million of revenue reductions across the system. I believe it's 39 million. Why? Again, why do we feel very strongly this should apply to the entire market? It is true that folks in the small group have limited or no options by its nature, the way this beast of a Titanic that we cannot turn a 180 in 1 year is set up, is that if you have a healthier population, consistently healthier, and enough people in your small groups up to 100 people, you can start talking to a broker, and they may point you towards, there's a level funded or self-insured option for you that will save you significant money. This includes nonprofits. I think Christine, the broker you had in here, gave an example of a nonprofit with 120 or 140 employees. So it is true that if your morbidity is what we call that, the experience of your employees, the claims experience, their healthiness or lack thereof, is worse than what the small group market is, then you're going to stay in the small group market. If it's significantly better, not 2 or 3% better, maybe not even 10% better to make the leap, you may start looking at modeling what it looks like to go self-insured. The reason we feel very strongly that there's two main reasons I feel very strongly the administration feel strongly they should apply to everyone in the financial market is that everyone truly is in crisis right now. These prices are out of control and everyone's paying them. Even if you're self-insured, maybe you have a healthier set of employees and you're able and you have better experience. So I don't feel comfortable telling that group, you can't have this option anymore. I don't like that you're paying your own claims. That's what self-insurance is. You have a business paying its own claims, getting some level of protection to stop loss, which I'll get to shortly. But I have real trouble with ranking the level of suffering that's happening because there are small business and nonprofits that are self-insured or even in large group that are paying these costs. And what that means for the employees of these companies, even if they're self-insured, because there is flexibility to manage that, those employees may have limited options. So you're self-insured with 100 plus employees, you don't have the option actually to go on the small group. You can either go fully insured through a large group product or you can go self-insured. With self-insured, you have some benefit flexibility. You have the ability to, and if the prices continue to get high, your flexibility is maybe I won't grow next year. Maybe I won't buy the extra storage space for inventory. Maybe I won't give raises to my employees. So these are very real things that are happening to small businesses and nonprofits right now. And of course, we see the impact on the state finances as well. The fund for health insurance for state employees is in deficit right now. And of course, the cost of teachers' health insurance is also high. It's just high across the board. So for me, fix it across the board. I understand the baby steps pilot program that can entirely be done by just adjusting or giving the Green Mountain Care Board the ability to set that rate at what is within the capacity of the hospital system as they go through rates and hospital budgets this summer. Second reason is that so the Green Mountain Care Board website has the UVM Liaison's latest report. That report is very sobering. It shows that's by far our biggest hospital in terms of cost. It's very clear that to right size the expense side of that hospital will take, I believe it's in the magnitude of $300 million of cost cuts over the next 3 years. That does not mean $300 million of savings to insurance. That does because that report to right size that entity assumes level revenue over the next 3 years. Level revenue to the hospital means no price reductions for insurers. Are there any questions about that? So $300 million of savings at our biggest hospital as presented to the care board and to the UVM board by a liaison who is not scared to suggest and show dramatic changes necessary assumes level reimbursements from insurers over the next several years to that hospital. I don't know what the scenario is in the other hospitals, but they don't have the magnitude and impact. So the other reason we feel, and I feel concerned about the idea that we'll take care of the QHP or whatever limited population this evolves into this year, and we'll move out to the rest of the market, to nonprofits, to businesses that are fully insured or self-insured, to the state, to VHI, is that I'm concerned that those savings may not be there in short order. So I believe, meaning we'll do QHP in 2027, and then in 2028, we'll grab another 100 million. If this dramatic report on the University of Vermont's hospital shows no capacity, at least in that cost savings plan, for reduced revenue, then I don't feel comfortable telling our business and nonprofit community that's not in the exchange, don't worry, we'll take care of you next year.
Well, I don't understand this though. You're saying that doing this for the QHP market right now, why bother? Because it's not going to have an effect anyways, because even though the money is coming out, which by the way, when they say money coming out, what they just mean is money less than what they anticipated the increase would have been. So, I mean, if they remain zero, right? If UVM remains zero
On revenue?
on revenue right now, you're making the argument that it's not going to affect anyone's rates anyways. Or it's not going to affect the QHP, even if we lowered that.
Not the argument I'm making at all.
Well, you're saying don't do that, but instead do like radiology or labs.
Whatever,
That won't have an effect either then. So why should we do anything?
whatever. This,
Why bother?
that line of questioning makes no sense to me, so let me restate.
Get prices under control.
We should get prices under control, because I guess the missing link there is hospital transformation. What will that yield and when? It's also true that the guidance from the board did call for $40 million reduction. So the board, which, tell me to shut up and bring them up here, but they must be anticipating that these, regardless of what this UVM report anticipates, that they expect some savings to come forward on revenue. What I am saying is, no, I'm not saying poo-poo the whole thing. Reference-based pricing is fantastic. It gives us a metric to start measuring this and identifying high-cost items that should be rationalized. And it's entirely within the care board's kind of jurisdiction to determine what's responsible to suppress rates, et cetera, on the pricing side, the hospital revenue side. I'm concerned by this concept that whatever comes out of the care board's work this summer results in benefit to just the QHP or whatever limited group this bill evolves into. I feel like that's going to be a lot of juice to squeeze from a lemon that's been very much squeezed in the last year or two. I'm concerned that there will not be anything meaningful remaining in 2028 and beyond, when the plan, as I just heard it, is to take care of the rest of the market. That's my concern. Does that make more sense?
Yeah, except I don't understand because they're charged with this.
Yes.
So I guess,
Well, have they been asked what kind of revenue savings will be in 2028? I don't even know.
well, I know, but they're tasked with asking those questions.
Yes.
And figuring out the solutions.
And we're tasked as policymakers, regulators, and legislators to understand not only next year, but the longer term. So I would be curious to know what type of savings will go to the rest of the market, what range, and if so, how does that estimate reconcile with is a very sobering report from the liaison.
Aren't you tasked with insurance insolvency or solvability or
Yes.
solvency?
Yes.
I'm trying to come up with a word.
Yes.
Karen.
I was just wondering if you could explain, you've summarized the UVM report. I haven't seen it. But can you explain if you're saving 300 million, why that has no impact on premiums?
So I'd really love to have the care board do that, but but essentially you had testimony from Dr. Leffler, who said they're losing money currently. Correct? That was this committee. So when a business is in the red right now, meaning they're losing money, I think at that point he was saying $500,000 a day. Cutting expenses doesn't mean you can cut prices. It means I need to cut expenses just to break even. And then as you do, does that make sense?
So far,
So then going forward, when you do these forward-looking financial statements, you say, all right, how much do we need? What, just like you see in school budgets and you hear from those authorities, cost of labor goes up, cost of fuel goes up, cost of whatever, electricity goes up, everything goes up. If you're going to keep revenue level, you have to cut every year just to keep up with the inflationary pressures on your income statement. If you're already way below profitability or break even, so that's how that happens.
that's the generalized descriptions. I understand.
Yeah, okay.
What you're saying.
Yeah.
I have to look and see the details.
You know what Dr. Leffler also said? That they're losing almost $500,000 a day because of decreased utilization.
That's what I was going to say. They
And-
can't afford to go.
Not prices, not decreased utilization.
But utilization is part of insurance cost and revenue. So if that persists, and you know the information I have from our regulated entities, the insurers, is not exactly showing that as a sustained long-term trend at this point. But if that persists, the insurance companies will see underwriting profit, and the care board will see that and can moderate that, and maybe they can deliver savings because of different utilization assumptions. But it takes more than a couple months of lower utilization to throw in with or to make big decisions based on that.
And it only takes 1 month for people to lose their subsidies before they realize that they can't afford to actually use the insurance that they've got.
Yes. I'm not saying there's not a crisis.
Services that they need. It takes about 1 month for something like that to show up. I want to ask you about, you talked about stop loss. Can you talk about attachment points?
Yeah.
And
So Vermont is one of, if I read this report correctly, the person who would have been best for this testimony was not available today. I think about 30, it looks like 38 states, no, sorry, 28 states? 28 states regulate stop loss. And then there's a footnote on 2. So about 20 states don't even regulate. Stop loss is insurance. Again, you decide you want to self-insure. You see that an insurer or a TPA, could be Blue Cross, could be Cigna, tells you, if you just pay your own claims, they'll be cheaper than being on the exchange, or you're not even qualifying for the exchange. So it's just between fully underwritten insurance versus self-insured. So you want to protect yourself for catastrophic events, so you buy stop loss. Stop loss usually has 2 different attachment points. It's essentially, if you consider an employer self-insured, consider it reinsurance, just like your homeowner's insurer has some level of reinsurance for some catastrophic tornado, hurricane, whatever. It's the same thing in health insurance. And that kicks in with these attachment points. One being individual. So you have 100 employees. If any one person's annual claims go over $60,000, say, the stop loss policy will pay for that year the rest of that person's claim. The other piece is called aggregate, which means my whole pool of 100 people in this time period if their claims go over 120%, is the example I'll use, of the expected claims, which is something that's worked out, that's estimated by the TPA and worked out with the stop loss insurer, then the stop loss insurer pays those claims in excess of the 120%. It's similar to like a deductible on your car insurance in a way, except for you're just one. So ERISA preempts state insurance departments from interfering. Again, I'm not an attorney, with an employer's right to just pay their own employees' healthcare claims. Stop loss is a way that states can reduce that kind of behavior, reduce the attractiveness of going self-insured. And we do that through minimum stop loss attachment points. The reason is, you could say, oh, I'm getting out of the exchange, it's too expensive, I'm going to go self-insured, get that ERISA protection, and buy 101% stop loss. That doesn't meet our minimum. That's essentially, arguably, I would argue, is health insurance masquerading as a self-insured plan protected by ERISA. So every state has a different approach, but that we're all clustered around the same area in how we protect the ability of an employer to go self-insured, something I believe is a right that they should have. But also they have to mean it, and they have to actually be willing to take the risk. So for us in Vermont, that's 120% of expected claims. That's the minimum attachment point for small groups. For large groups, I think it's 110. And then on the individual level, it's currently $40,000 for small groups. So you cannot, in Vermont, as a small group, go self-insured and say, I want a $35,000 attachment point on the individual risk level and 115% on the aggregate level. That's not allowed because stop loss is an insurance policy that we regulate the rating and the policy language of.
So it's 40,000 for an individual.
Yes. And every 3 years, we are tasked with doing a study of if we want to stay at that kind of realm, that number should go up because the cost of health insurance goes up. 120% doesn't matter, because that rises and falls with the cost, not the cost of health insurance, the average claims. So this year we got to recommend, we per our regulation, hired Oliver Wyman to look at that question. They recommended we change the 40,000 to 52,000 for the small group. We opted to not do that because our response to this cost environment we are in is very much not about restricting people's options. So that could put some small groups and nonprofits that are currently self-insured, like being self-insured, are able to offer insurance in this environment, in the position of having to now go back into the small group. And while you might not design a system that way, that's the system we have. And that is the decision we made to not adjust those attachment points this year.
When is the last time you increased the attachment points?
I believe 3 years ago, but I'm not certain.
So 3 years ago, and you've now decided that you're not changing them again.
Correct.
That's going to be 6 years.
Well, we can change them anytime. We're not limited to changing them every 3 years. We're just in the reg, we state that we will go out, we'll do an analysis every 3 years, and then the commissioner may change the attachment points.
So I think I'm trying to wrap my brain around all of this, but you make the argument that everyone should see the benefits, and yet by keeping the attachment points where you are, you're essentially insulating the self-insured market from the increases in healthcare spending.
No, they're paying it. they're paying for, they still have to pay for the stop loss coverage.
40,000 and then at that
But
point,
they have to pay for the stop loss coverage. So that stop loss provider, which Blue Cross is a stop loss insurance provider, will charge them. There's a premium for that. So one way or another, they'll pay. They are not being insulated from the healthcare costs, nor their employees. They just have another mechanism protected by federal law to just pay their, employees healthcare claims through this arrangement. I also want to point out that in the study, which I will get the final study and send it to the committee, all I could find, since you asked me yesterday to come in today, all I could find was a draft study, but the numbers are the same. Vermont is quite, if we say conservative is a high minimum attachment point, which makes it harder to makes you take more risk to be self-insured. Vermont is relatively conservative compared to all the states. So I'd say middle of the pack, if not more conservative, at $40,000, $40,000 for small employers, and 120%. So you see a lot of states clumped closer to 110% of expected claims, and $20,000, a couple in the 20 to 30 range. So there's a chart in that report that I'll send you. So by no means are we permissive when you look across the state landscape. Again, with looks like 18 or 20 states that don't even have a regulation on stop loss.
I think the thing I'm struggling with is you're making decisions which are important decisions, and I fully honor your ability to, because we have given you the authority to regulate this.
Yeah.
And you're I don't want to say these strings, but you're using the regulatory strings that you have to influence that market. So the Green Mountain Care Board, they also have regulatory strings to help the markets that they regulate, which is the QHP market. And when we're talking about hospital pricing, and particularly if we're talking about reference-based pricing, we've given authority to the Green Mountain Care Board to concern themselves and use the tools at their disposal, because we've given them the tools to be able to do that, just like we've given you tools. And first of all, I find sometimes that you all, and I don't mean this in a personal way, in any way, because it could be anyone, but then oftentimes you're working at odds with each other in your regulatory capacities. In a way, the self-insured market is undermining the QHP market. The QHP market doesn't have the advantages of, what you just talked to us about, which I will probably forget by tomorrow. And yet they do have levers that they can pull. So
those levers don't change the cost of care. Those levers include reducing benefits and asking for greater cost share of their employees. I'll say that we take our regulatory responsibility very seriously, and I know the Care Board does as well. And I think 99% of the time we're on the same page, for the record. What we do is balance employer choice in an extremely stressful environment that everyone in this room agrees cost-wise. So there are employers, and which includes nonprofits, that if we adjusted those stop loss attachment points up, many of them, we would simply just be adding cost to them. And they would either reduce benefits or move into the small group. And I know that I know we want more lives in the small group, but we have to deal with this much more systemically than just reducing rates or reducing costs for one group of insureds.
I absolutely agree with you that we should be treating this more systemically. And then we're going to take a break.
Just one small question. If the attachment point is higher, premium it affects the premium. If you keep it lower, it's a higher premium.
Well, I guess it makes them bear more of the risk and more uncertainty and makes it harder for them
Does it
to.
impact premiums or does it? I understand.
There's no premium really. Well, stop loss premium.
Yep, that's what I'm talking
That would go down.
Yep.
But the risk that the employer is taking
Yeah.
would go up.
Yeah.
And so it's not, when you're a self-insured group, your TPA or insurer, because insurers act as TPAs, will say, we estimate you're going to be at $700 per person per month. That could be $7,000 per person per month. That's why you buy the stop loss. So that cost.
But so when the premiums go up, the cost to other people goes up. I mean, the folks paying for the self-insured groups.
Self-insured groups is an employer paying their employees' claims and protecting themselves by buying and paying for stop loss insurance for more extreme events.
Taxpayers pay for those claims. Right?
Taxpayers?
Yeah, they pay for, you're maybe thinking of a nonprofit. I'm
Oh.
thinking of the two big ones.
Oh, okay, yeah,
So we taxpayers.
Yes.
If you have a higher, whatever,
attachment point.
attachment point.
Right.
the Premiums go down. And so cost to taxpayers may get impacted. I'm just trying to understand if there's a relationship.
Yeah, I think you're correct. But that relationship, you pay less than your stop loss, but you take on more risk. So you're over,
Yeah.
you could end up paying more overall. But yes, and I do believe, I think that, and again, this, if it matters to the committee and their deliberations, check with someone other than me, but I believe the state and the teachers is not necessarily an ERISA plan. It's certainly the teachers is a statutory arrangement in Vermont, and the state, not sure about government ERISA interactions, but it's the same concept.
Dave,
Are there insurance companies who are in the market for stop loss or reinsurance here that aren't in the normal insurance market?
Yes, Cigna is the biggest, and there's a couple minor ones. But for the most part, by my count, over 90% of the self-insured market, if I include state and VHI, is between Blue Cross and Cigna.
Thank you.
And Cigna is the only one that's not in the QHP. MVP doesn't do self-insured in Vermont.
all right, let's take a break. Thank you, Commissioner.
Thank you.
It's always hot when you come into this room.